Okay, so a very good morning, afternoon, and evening to all. I'm Dr. Priya Balasubramaniam, a senior public health scientist at the Public Health Foundation of India, and I direct the Center for Sustainable Health Innovations here in Singapore. It is my pleasure to welcome you all to the Mutual Learning series on digital health ecosystems. In this series, we examine evolving digital health interventions through a health systems lens in preparing for inclusive, integrated, and accountable digital health models beyond the pandemic. Today's digital dialogue will focus on matters of inclusivity in the design and governance of digital health in India. Our panelists will discuss to what extent have digital tools as well as models that they have developed during the COVID-19 pandemic or earlier increased or improved access to health services by vulnerable and underserved populations, and what measures can be taken to address inequalities that have emerged. The format of this roughly 85-minute session will involve an initial 5-minute introductory pitch where panelists will focus on their work in response to COVID-19, what they are doing now or planning to in terms of adapting services as well as governance model, particularly with regards to the key question of inclusivity in design and governance. It is now my pleasure to introduce you to our speakers as well as my co-moderator for today's session. We have Madam Sujata Sonik, a senior officer at the Indian Administrative Service, who currently serves as Additional Chief Secretary of the Department of General Administration, the Government of Maharashtra. She's a former Takemi Fellow in Global Health at the Harvard Chan School of Public Health, and she has 3 decades of public policy and governance experience in healthcare, finance, education, and disaster management at district, state, and federal levels. Welcome, Madam Sonik. We have Shipra Dawar. Ms. Dawar is the co-founder of eCyclinic, an online mental health focused startup, and I Will, the first structured and recovery focused therapy platform. Both eCyclinic and I Will have worked with several state and district governments in India in relation to the COVID-19 pandemic to bring last mile mental health accessibility to all. We have Mr. Sanjeev Chabra, a volunteer at Project Step One, a volunteer-driven telemedicine initiative that was launched in response to the COVID-19 crisis. Having traversed several continents and professions in healthcare, technology, and human resources, he's returned to India to leverage his skills, experience, and expertise to contribute to universal health coverage in India. We have Professor Sarthak Gaurav, an assistant professor in economics at the Shailesh Mehta School of Management at IIT Mumbai. He's developing dashboards on nutrition and health indicators with a team from the Center of Technology Alternatives for Rural Areas, also at IIT Mumbai, that diverse stakeholders can benefit from. And finally, my co-moderator for today's session, Professor Jerry Bloom, who's a fellow at the Institute of Development Studies at the University of Sussex, with a long-standing interest and experience in projects around mixed health systems, technology, and innovation. So welcome to you all, and let's get started. The first presentation for today's session is by Ms. Shipra Dawar. Over to you, Shipra.
Thank you so much for that introduction, Dr. Priya. It's an honor to be speaking for such an important topic, really, and that's about inclusion in healthcare. Just to give you a brief background of what we did pre-pandemic, I Will an eCyclinic is an online mental health provider, and we've been working since 2015 to make mental health care access possible in India through clinical evidence-based recovery programs. This was largely an app-based system, and our commercial product is still largely for people who have higher tech literacy, for people who are in urban centers, for people who have the payment infrastructure as well to access such models of care for mental health, psychiatry, and psychology based over the app and the phone. We have a large presence now in India, and we've also launched our care services in Sri Lanka. COVID 19, when it struck in 2020, it really posed a big challenge because mental health challenges were at a meteoric rise with the lockdowns, with migrants stuck at various parts in the country, ASHA workers struggling, the healthcare, the whole healthcare machinery really struggling with the sudden on workload and sudden anxiety and uncertainty to how to manage this pandemic. And that, as a team, made us think about what could be our contribution to provide mental health care access to anyone who needs it. And the product that we had essentially was an app based product. Now, the moment you are thinking inclusive mental health care, you have to think about people who don't have smartphones, who don't have access to internet, who are probably sitting in rural India, who are providing access to healthcare as ASHA workers and Anganwadi workers in the very farthest corners of the country. How do we provide them the counseling service that they would need currently today? So what we did was we created a complete telephony based mental health care system. This was a complete shift from our operations, which were largely app based, video based, tech driven. So it was completely a 180-degree shift, in terms of organizing a different form of care. What we also did was we launched these helplines and the web spaces in 15 different languages in India, and also created about 13 modules for mental health care targeted at very different populations. So migrant laborers was one, ASHA workers was the other, rural healthcare workers apart from ASHA workers was the third, police professional and people at the frontline settings, people who were struggling with COVID, people who were marginalized because of the financial crisis, business professionals, small business owners. So we created modules. We trained a huge army of psychologists in those models and launched this initiative. Now, we launched something that was really needed, but as a startup, your reach isn't there. I mean, you need to tie up with the right bodies who can potentially distribute your service and your product to the people who need it. And that's where our partnership with ACT Grants came in handy. They supported our initiative with the funds. Bill and Melinda Gates supported it, and they helped us chart the course of partnerships with state and district level governments. So we had a partnership with Maharashtra State Innovation Society through the ACT grants. A lot of districts in Maharashtra, a lot of districts in Haryana State at the center level, Rajasthan State at the center level, Karnataka districts, and that became the model of partnership to bring our mental health care services and use the government's support to disseminate the help to the right people. This did create a huge impact on ground. We could do more than 4 lakh counseling sessions. 18% people repeated, and the ones who repeated were from all walks of life. 40% of all the users of this counseling service were from rural India, and that was a testimony to the fact that the government also had disseminated it very, very affirmatively at the right places that it needed to be disseminated to. Also, what the helpline and the call based system and the module based system allowed was huge replication. So, what we had launched in, say, a district in Pune could be replicated in several other districts in Maharashtra and then several other places in Haryana, and so on and so forth. Some really interesting impacts also came about. ASHA workers who we were counseling for, they were struggling with the supplies, and they could get those supplies because we were the first point of interaction for them in the time of a huge crisis. So not just mental health help, there was another impact created where we became almost the first line of communication with a large audience of people that otherwise would have been left out. I think another key interesting aspect which allowed us to scale was how the Maharashtra government and specifically Maharashtra State Innovation Society really trained people at the primary healthcare centers and community healthcare centers about what this initiative is, how this can be accessed, where it is available, how one can reach, and even dialing in people for them when they needed that help. So that kind of last mile dissemination and distribution really helped in, letting this solution really scale to the way it did. Inclusive and mixed health systems have a huge opportunity in my own experience during the pandemic. However, I do see that there are areas of improvement that need to be addressed. In a post-COVID or a era where we are living with the pandemic and where we are looking forward. One is, how do you sustain such innovations continuously and continue to serve the people who would need mental health care or emotional health care through these models? What are the ways in which new models of engagement can occur? And that's the question that's still unanswered to a degree. The other thing is, how can academia be involved? Because research, evaluation, testing these models is important so that they actually become, a part of the mainstream, delivery. In response to these questions and in response to what we saw needs to be done now, we launched an integrated platform called I Will Care. The idea here is to have the helplines, the counseling service, have AI-based support, in different rural languages and dialects, but also integrate other tertiary, care NGOs and the ones who are working at the last mile and really offer their services as well seamlessly through our own ecosystem and be a part of that ecosystem as opposed to trying to replace it, because I think a lot of work needs to be get done in tandem together. So really, that's the presentation that I had for all of you today. Thank you so much for allowing me this opportunity to share what we did, and I'm very much looking forward to the discussion and the presentations after my own. Thank you.
So thanks, Shipra. That was a great presentation, and look forward to the question and answer session that's going to follow very shortly. Our next presenter for the session is going to be Sanjeev. Over to you, Sanjeev.
Thanks. Quite a different story from Shipra's. We did not exist before the pandemic. So briefly, what I'm going to cover with you in 5 minutes, I'm going to be very ambitious and try to telling our story in 5 minutes. But in speaking to Priya, she's asked to kind of explain a little bit about the genesis. So I've broken that up into two components: the conception and birth of step one, the evolution that has happened over the course of the past 18 months, what our strategy was at the time of designing our interventions, the inclusivity component of it, and a little bit about the lessons that we've learned. So basically, we did not exist till March of 2020. There was a bunch of people that knew each other, but we did not exist at all. And it all started with the lockdown happening in India and a bunch of us techies and other people coming together and saying, what do we do? Because we started to call some of the helplines and we didn't really get response. So given the fact that, there's a whole bunch of techies within our organization, we figured that technology would be a very, very significant enabler in this pandemic. So that's how we were kind of conceived and born. And it started off with a small effort, speaking to the government of Karnataka, saying, hey, can we take some of your call volume off? By means of which, you can focus on the calls that are of importance to you. And from there, it's mushroomed into a whole bunch of stuff. And again, share a little bit of those details. What we evolved into is an organization, and I prefer to think of us as a for impact organization as opposed to a not-for-profit organization, because our agenda always has been to have impact rather than saying we are not going to make a profit. We're completely run by volunteer. I'm a volunteer as well, and so is the co-founder and everybody that's contributed to the organization, with the exception of during the second wave. At the peak of the second wave, we had to hire some people because the call volume was very, very high at that point in time. Our vision itself is one of inclusivity, to basically say that we want to create a world where nobody's deprived of healthcare. Very audacious. We'll start off with India at this point in time, but we believe that, with the forces that come together, it's possible to actually do that. And our mission is to essentially blend technology and human resources to provide healthcare access to those who need it most. Just a little bit about what we did, what we took into consideration when we were building our technical platform. So on the right hand side, you can see that there are criteria that we've listed, which is age, location, language, and socioeconomic. And as Shipra had alluded to earlier on, we needed to make sure that given the diversity of India, that whatever help was available should be available in the local language. Obviously, we wanted to ensure that anybody at any location, in any language of any age with any socio-economic status would do that. So our call was essentially our entire services were completely free. Our approach also was a very patient-centric, but I'm going to change that to a citizen-centric approach, because a lot of the people were not our patients as such. They were citizens that are reaching out to us. And again, from an inclusivity perspective, we realized that physical health is not enough. We had to address anxiety and other mental health related issues as well. So basically recognizing that the patient is at the center of care. And from that, we determined who were all the stakeholders that we would like to engage. So going clockwise, obviously the most important one was the government. We had to rope in the private sector to be able to avail private facilities and the private healthcare system. Given the fact that a large component of the load was going to be borne or managed by the government, the public healthcare sector was also a very, very important aspect of our ecosystem. Then obviously there's the doctor, there's allied health professionals, there's diagnostics. Then there were the actual citizens, and I've broken the citizens down into two components. One is those who were the outreach, basically, who were the people who were taking the call, the receiving the calls, making outbound calls. And then there was everything that was happening behind the scenes with people such as me and the technical team that are basically managing the entire operations. So I'll rush through this right now. Basically, we ended up developing a technical platform. Again, keeping in mind that, COVID is here today, going to be gone tomorrow. So our technical platform was designed such that it could incorporate any clinical process. It was also, as Shipra alluded to earlier on, we wanted it to be accessible through voice, through a smartphone or through a PC. So it's completely universal and agnostic of the type of technology that we use. And our platform has a rules-based engine, which enables clinical decision support. In COVID, this is what we ended up doing. We needed to monitor people at home. We can actually slip the slide. Basically, it's just about what we did in COVID. We were tracking people who were at home. We were escalating cases to the government. And of course, we were providing a lot of counseling to people on the phone. Very briefly, the spectrum of the solutions that we developed from pre-COVID to post-COVID management, including vaccine ushering to encourage people to get vaccine. We did COVID suspect triaging. We had mental health counseling in several states. We did COVID positive triaging. And probably one of the largest components of what we did was monitoring of patients at home to ensure that they didn't get into critical condition, or if they were changing from being stable to getting into critical condition, to get them care very, very rapidly. What are some of the valuable lessons that we've learned over the course of this journey? We've understood that technology is very cool and it's very sexy, but people and processes must be incorporated into it. And just technology, even providing the best technology in the world to the government, would not be sufficient. We also realize that, there is an existing system that is already there, and rather than starting from scratch and being a standalone system, augmenting what was already available would be of tremendous value. Third thing that we realized was that there is an existing infrastructure and we should not have to start from scratch. We utilize the existing infrastructure and figure out what are the lacunae in it by means of which technology can come in and bridge the gap from that. The fourth thing that we realized is that engagement of stakeholders is very, 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 very critical. And because we've been present in about 20 different districts, we've noticed a level of engagement that varies from state to state. And the best outcomes we've had is in the states where, there has been all of the stakeholders have been really deeply engaged in the entire process. This is something that we realized in the next point is we realized in the second wave was that holistic intervention must include on-the-ground presence. So for a person who doesn't have a concentrator, for a person who doesn't have oxygen available, you really cannot manage things remotely. So going forward, the on-ground presence is going to be part of what we do. We already started moving beyond COVID. We've gotten into breast cancer management. We're doing a primary care project in rural Andhra Pradesh, and we're doing a maternal and child healthcare project in Tamil Nadu, which should be launching over the course of the next 30 to 45 days. Thanks for this opportunity. Great to meet all of you. I look forward to the conversations that emanate after our presentations, and let's change the landscape of healthcare in India.
Great, Sanjeev. Thank you so much for that presentation. I think it gives there's a lot to think about on how the future of health systems are really going to look like. And with that, let me invite Madam Sujata Sanik, who's going to give a perspective from the governance and as a pioneering person in incorporating various digital technologies in Maharashtra. It'll be great to get her thoughts on this. Over to you, Sujata ma'am.
Thank you so much, Priya, and to all the colleagues who have joined this discussion today from IDS as well as PHFI and colleagues from the startup community also. So I will begin by saying innovation disruption. What is the first thing that comes to our mind? Startups. So digital transformation of healthcare can be disruptive. Technologies such as the Internet of Things, virtual care, remote monitoring, artificial intelligence, etc., have proven potential to enhance health outcomes. During my recent assignment, when I was working in the Skill Development, Employment and Entrepreneurship Department of the Government of Maharashtra, I had an opportunity to work with many startups across different sectors. The pandemic, in fact, brought in its wake a need to collaborate, and each one of us was very keen to start contributing to the response. Many of these startups were winners of our Maharashtra State Startup Week, which we organize every year through the Maharashtra State Innovation Society, which is a body which is very unique to this state. It is part of the Department of Skill Development, Entrepreneurship and Employment, and it is a young body which is manned by qualified people who are very well connected to various stakeholders in the industry. So this society became the nodal agency under which we started to open up collaborations with different startups. And they played a very crucial role in our response to the pandemic. Let me give you a little bit of a window of where Maharashtra is poised in the country vis-a-vis other states. We often hear about Karnataka and other south states. I would like to just point out what are the statistics of Maharashtra. So we have around 14,800 startups which are registered in Maharashtra. Through the Department of Skill Development, we have been supporting 17 incubation centers. These are mostly co-located in the state's various universities. Maharashtra has emerged as a winner in 3 out of the 7 reform areas of startup rankings in India by the Department of Information and Technology, which is number 1, seeding innovation leaders, number 2, scaling innovation leaders, and number 3, awareness and outreach champions. So as you can see, a lot of our work has been around, connections with these young, startups who are keen to get into the healthcare sector. Interestingly, 5% of the total startups in Maharashtra are in the healthcare domain, which is not a bad number to start with. Mumbai has the 3rd largest startup base in India. Government policies and initiatives so far have been creating of a fintech policy in 2018. And also we have a startup policy also from 2018. So it was very fortunate that we had these policies in place before the onset of COVID-19 pandemic. The state startup ranking in 2020, Maharashtra has been termed as a leader, and we are very happy with that. And globally, in terms of growth, we have been signing a lot of agreements to bring to onboard other startups to work with us in the coming months. Now, patients want on-demand healthcare. Physicians and hospitals need big data insights. Medical wearable devices improve preventive medicine. Using AI as an enabler to provide personalized treatments and use of virtual reality to help doctors get better trainings. All of us have this on our wish list. How are we actually going to achieve it? That's the big $1 million question. A special incentive scheme to support startups in telemedicine, digital health, and artificial intelligence through the Biotechnology Industry Research Assistance Council, also called as BIRAC, an enterprise run by the Department of Biotechnology, has been working exactly on those areas. BIRAC has been supporting and promoting new biotechnology ventures under its Startup India and Make in India program. Perhaps you've heard about these terms. It has so far lent funding of over 21.28 billion, that is almost 280 million US dollars, to around 1,500 startups, enterprises, and small businesses. The council has also extended support to fledgling startups who, prior to the pandemic, were struggling with issues such as rising patient demands or aging populations the increase of lifestyle diseases, and growing costs of delivering care. So, some of these ailments which are plaguing our public health system were also the areas where we found that there was a lot of startup activity looking at gap areas and trying to reach those who have not been surfaced so far. These pressures had forced our healthcare providers to come up with new solutions like employing medical answering services to enhance the quality of healthcare services as well as lower their prices. However, the pandemic hit the world and introduced other challenges, exposed gaps and vulnerabilities in the healthcare space. Still, it presented new opportunities that have helped health tech startups to showcase their abilities and innovation. You just heard the experience from two. There are so many more in this sector, but we don't have time to go into all of that. The COVID-19 pandemic is expected to have lasting impacts on the traditional method of doing business in the post pandemic era. And that's where I feel, as a government, we need to also become smart. Everything around us is becoming smart. We also need to become smart. And how do we do that? We have to bring on board those groups and companies who are interested in partnering and doing collaboration. A study by Zheng et al. 2020 reported that as infectious COVID 19 persists, contactless services using advanced technologies are likely to infiltrate people's daily lives, which means we can only ignore this at our own peril. It is expected that the current growth trajectory of telemedicine will continue in the post pandemic era as patients have generally been satisfied with remote healthcare services without face to face encounters with their doctors. Everyone has found value in this, and we need to build on these opportunities that have now emerged. The pandemic will not be the last one. New ones will surely appear in the future. In fact, there's a study by Jones 2020 that says that healthcare industry, especially public health, must not only manage the current pandemic well, but also be prepared for future pandemics that will most likely disrupt everything in a greater magnitude than the current one. Which means what? Already there's disruption around us. We have to partner with startups. And that is what we have tried very successfully. And I'll be happy to discuss more of that in detail as we progress into this discussion.
Thank you, Sujata ji. So that was a very interesting overview of how the government has been thinking about startups and technology. But I have a lot of questions going down the line. But last but not the least, I'd like to invite Professor Sarthak to really talk about issues of equity and inclusiveness and what his experience has been in working in this area, especially around digital health.
Sure. Thanks a lot, Dr. Priya, and thanks to all my speaker colleagues here who have given us a lot of insights into the initiatives that they had, not just during the COVID pandemic, but before, and they continue to do so as well. So I'd be focusing on some important questions on inclusivity in digital health. If you look at this image that is run through several variants over the years, had this been a classroom, I would have spent at least 50 minutes discussing the subtleties of the distinction between equality and equity in digital health. So one question that has really prompted our conceptualization about principles of equity and inclusivity in digital health has been that if you compare the image on the left to that on the right, is it enough to retrofit a ramp out of a box to attain equity? So what does that lead to? That leads to this important question of having ramps as an afterthought. In other words, it's very important for all the stakeholders, including much of our partners that could potentially evolve in our attempt to have universal health coverage with inclusivity as a core principle. It is important to understand that we need to talk about inclusivity right at the word go. So right from the design, the principles of equity, the principles of inclusivity have to be born in. So what we understand from our conceptualization of equity in the health perspective, particularly those differences in health outcomes that are unnecessary, that are avoidable, that are unfair, and that are unjust. So these are the inequities that need to be addressed. They also spill over into the space of digital health, and that too in several forms, many of examples that the speakers have already talked about. So one particular area of our engagement with this questions around conceptualizing equity in digital health has been, do we need to go beyond access? So our experience so far has been that yes, there are several critical factors, including design, skills, the confidence to navigate a certain digital health ecosystem and devices included, questions of privacy and security, particularly data protection, privacy and security, interconnectedness, algorithmic bias, and that's one area that I'll be happy to talk about later, and several questions about standards and compliance. So if you really start visualizing an ecosystem where several partners and stakeholders are coming together to deliver inclusive digital health systems, we believe that we have to tackle these questions at some point. Now, talking about the need to conceptualize digital health, right, before we get down and tinker with several models and the tech, as Sanjeev really indicated, we have to understand that digital health offers several idiosyncrasies. This is largely because of the broader scope of the digital health. Whatever categories we might be working on, be it telehealth, be it telemedicine, the health infotech, the wearable devices, or the clinical decision support systems, you realize there might be specific needs for inclusivity in these sectors, and there's a lot of intersectionalities. Heterogeneities and vulnerable subgroups and the local context are very interesting variations that we have come across in our work in the IIT Bombay's dashboards initiatives, where particularly during the COVID, in May 2020, we began developing a portioncovid.in portal that will not only give very valuable information to stakeholders about monitoring and about nutrition, early childhood development, but also that integrated into our other initiatives and dashboard building in the health and nutrition context. And there we realized that any decision support system that is being designed should not only be catering to the needs of a top-down perspective, but also a bottom-up approach could be developed. So we believe there is a pressing need to develop such frameworks where you could have inclusive digital health being talked about, because there are certain general frameworks for health equities, and we believe there is scope for us to really discuss and have a dialogue over a period of time to arrive at a set of guidelines as well as a framework for digital health. So finally, a question that really arises here is, can we really improve the outcomes? So can we really improve the outcomes is as difficult to infer based on the title of this slide, because there are some letters out there. We don't know what it indicates, but some students, when I show this in the classroom, they make some meaning out of it. They say, maybe this means, can there be outcomes, or could there be outcomes, and so on. It's meaningless. So what happens here is digital health particularly offers several challenges because we mostly focus on measuring processes rather than value-based healthcare. If you're focusing on measuring processes rather than the value in healthcare to the end users in particular, that includes both the patients as well as the providers in many contexts. So we have to realize that we have to make a shift from the volume-centric to the value-centric evaluations. Variations by digital health solution categories is what we've already seen. A lot of challenges in evaluation because you have to understand the innovation diffusion process. So there have to be players who are early adopters or innovators, and there will be late adopters and laggards at some point. So we cannot just evaluate this as on an average effect in a certain system. We have to pay attention to the diffusion spectrum. And finally, if you see, there are several guidelines in place for technical validation, clinical validation, as well as the system validation. We have to bear in mind that the questions of data ownership, privacy, and security will play a very important role. So I leave all of you with an interesting talisman that appeared in our textbooks back in school, which was given by Mahatma Gandhi. So the crux of this talisman is that Gandhi is talking to your conscience in a way, saying that I'll give you a talisman. Whenever you are in a doubt or when the self becomes too much with you, apply the following test. And I want all of you to apply this test in the context of inclusivity in digital health. Recall the face of the poorest and the weakest man or woman whom you may have seen, and ask yourself, if the step you contemplate is going to be of any use to him or her, will he or she gain anything by it? That to us is a very important moral compass in designing inclusive health systems, though we also tackle with the frameworks offered by John Rawls as well as Amartya Sen, among others. Thanks a lot.
Thank you so much, Sarthak. I think the last slide left us with a lot to think about and perhaps could be a starting point of the discussions to come. So at this point, what I'm going to do is I'm going to turn the platform over to my colleague, Professor Jerry Bloom, who will start off with the first salvo of questions so that we can get the discussion started. And and then as the discussions progress, we can focus on specific talking points that we want to elaborate on. Just a quick thing to think about is when you're giving your responses, maybe you can just kind of keep that brief to about 3 to 4 minutes so that we can have more questions to kind of field, and the discussions could be richer. So over to you, Jerry. Let's get started.
Okay. Well, first, thanks for 4 really excellent presentations that put a lot of the key issues on the table. And I guess I want to go back to what Rajiv said about audacious goals. And I think what's clear is what we've seen, certainly with these 2 interventions, is very audacious ways of really responding to a crisis. And people have been very busy now in putting together major interventions. And I'm wondering now, a year or so down the line, if it is time for a bit of reflection. And I just wanted to ask a couple questions about reflection. And I guess, is this time now to think about what's learned and what can be applied for the future in thinking of what Professor Gaurav has said? So first to Ms. Dawar on PsyClinic. It would be good to hear your thoughts on, as you spread this, what are the key barriers to people's ability to benefit from the service? And how do you know, what's your source of information on who has benefited and who hasn't? And then once you reflect on that, when you think now, what are the strategies you might employ to overcome these barriers? So it'd be very good to hear your thoughts on that.
Thank you for that question, Jerry. And it's been at the time when the pandemic struck, like Sanjeev was mentioning, all of that was so fast in how we evolved our solution as well. There wasn't much time to really reflect and think, though we were trying to understand from various stakeholders how we needed to evolve. So some of the points that I'd like to highlight in terms of what we couldn't achieve, and this is something I wish to be candid about it, is that even when we were a solution that could be used by the rural India, or people who aren't necessarily as they don't have the kind of access to healthcare like we do in the cities. A lot of people were left out. So a lot of people, when it comes to mental health, don't even know whether they could be dealing with it. And so, whether they should call a person, and they could be very, very, their severity of mental illness could be so high that rather than they speaking to counselors, they need medical health intervention. So they need a psychiatrist, or they need a peer support group, or somebody who can visit them down the line at the ground where they are. And that solution wasn't providing, ePsyClinic wasn't providing, and wasn't even thinking about how to provide. So as the pandemic subsided, and specifically in the places where we were, these conversations started to happen with the district administrations and the government officials and other key stakeholders who look after community welfare, that how are you going to play a role? And if you can't play a role directly, can you be an enabler where in such dialogue can begin and care can be provided eventually to these people who are completely left out of the spectrum. So this is an area where we are working currently in terms of how do we magnify the problem there for the last mile. And as a startup, what are the places that we need to move forward where technology can help, where our intervention can help? And what are the places where we need to take a step back and allow someone else to come in, and we enable that coming in of another entity. So to give you an example, in the district of Gurugram, we very recently partnered with a peer-to-peer mental health support group that works with people of severe mental illnesses like schizophrenia or bipolar disorders, and those who reside in the very, very rural and very remote areas of an urban city like Gurugram too. And they work on on the ground. So we just facilitate working with them. In terms of your second question, which was around how do you know that this worked? What were your sources of information that this worked? So when we started during the pandemic, we had very, very few data points to collect back that did tell us very effectively that this was working. We had to look at nuances like people are really thanking us that this is available, that they're rating the service high on the phone, they're punching, a certain hashtag to say that they liked it. The government officials were getting feedback from the ground and they were saying eSci Clinic is doing some good work. So what we've done now is that we've included PHQ-9 and GAT-7 assessments for depression and anxiety, and these are done in local languages. These are done over the call. So wherever we are providing therapy or mental health services through these partnerships to the individuals who are seeking help, we track whether the person is actually recovering on those accounts for us to be able to say that this is working.
But then, Sanjeev, it's the same question, but it interests me that that eSci Clinic also started thinking about what is the on the ground presence and what is the online presence. And you already mentioned that. Well, basically, what are the factors that enabled people to benefit from your services, and what factors meant they couldn't? And what adaptations are you thinking about now? And I guess particularly, what are your thoughts on this issue about the online and on the ground presence, and how much is this going to be with inside your interventions, or how much are others going to be responsible?
So I think our ecosystem is going to kind of morph a little bit over time. Like I said, during the second wave, we clearly understood being a virtual organization has certain limitations. So one thing we are very clear about the fact is that there has to be on-ground presence to be able to deal with physical intervention when required. And the physical intervention could be as simple as collecting somebody's glucometer reports to, monitor blood sugars, or to measure somebody's blood pressure from a non-communicable disease process, right? I think, a lot of our reflections, quite different from Shipra, a lot of our reflections were iterating throughout the pandemic and continue to do so now because of the changing situation, because of the changing clinical guidelines, because things kept morphing. We had to morph to be able to do that, right? I think possibly what I see as the biggest barrier is, when there is a crisis, everybody comes to the table and is wanting to solve the problem. Whether it's a weather crisis like the tornadoes that hit through, much of the US yesterday, to the pandemic that's happened all over the world. But let's not forget that there have been, quote unquote, other epidemics that have been prevalent in India for decades now, whether you look at tuberculosis, whether you look at leprosy, whether you look at, I think that our biggest concern right now is that once the pandemic ends, will the movement of what we've started in terms of citizens coming forward and contributing to healthcare, and citizens include all of the stakeholders within the healthcare system, will those people continue to stay engaged because the pandemic has ended? There's no longer a crisis that's in the main media every day. So we're trying to think of other models by means of which we're going to be able to sustain this. But fundamentally, we feel that what we've built in terms of the platform, the foundation, in terms of you monitor somebody over a period of time, you do early intervention as required. And this is not rocket science. This is, what the healthcare industry preaches for a long time. Prevention is better than cure. And then when there is a crisis, you escalate to an existing healthcare infrastructure with whatever resources are available to be able to alleviate the issue. So that's kind of where we are at from a step one perspective.
Right.
Well, it sounds like both of you are now putting directly the question to Madam Sonik.
Yes.
Which is
very much so.
What capacities does government need to build to ensure that all social groups benefit from digital innovations? It's good to see there's a lot of energy that's gone in, a lot of creativity. Now, how does government make sure that people can really benefit from this in the long term? Madam Sonik.
Yes, thank you very much for asking that question. I'm very happy to share my thoughts on it. Let me rewind a little bit and go back to before the pandemic hit. So you would all recall that the government of India had launched what was then called as Ayushman Bharat Health Mission, and it has been rechristened as Ayushman Bharat Digital Mission. It's become ABDM. So well before the pandemic hit, the country was already programming itself to creating digital platforms for a repository of not only people who required intervention, treatment, but also creating what we would like to call as a health ID. Many states of India have already created the health ID. We also have a lot of services already linked to the Aadhaar KYC, and we were also in the process of building a direct beneficiary transfer system for online payments through the banks. So the banks had started to play more and more an increasing role in the way we were going about addressing issues of health sector, not only health, but also it expanded to other sectors like agriculture predominantly, and old age pensions, etc. All this kind of a structure was being created. What the National Health Agency was also focusing on was creating a repository for all the health providers and also the health facilities. And some of these digital platforms have been very useful for our startup community to immediately access information. Then the pandemic came, and we got kind of overtaken by that deluge of too much information to process. There came a time when you had to really struggle to make sense of all that was coming in, and that's the time when, in Maharashtra particularly, with the AI Vadhwani group, this is a group linked to Stanford University, we signed an MOU, and they have been working with the public health department to look at the data and give them trends and projections as to where they see the next possible challenge coming, and accordingly drug procurements, movement of medicine, movement of personnel in the health facilities of the public delivery system, healthcare delivery system has been positioned. So we are already using AI to track where all are the unreached sectors where perhaps we need to put our foot down once more.
But I wonder, we heard from the innovators what they're asking of government. You've heard about the energies they put in and what they've created. What advice do you have to them about really adapting those kind of interventions so they can really work with what you have on the ground?
Yes, I think the most important message I have for them is that they should continue to innovate, because every experience of theirs is also telling them what are the unserviced areas, what are the challenges that still plague us. And given the situation we are all in, you have come forward to partner with us despite the big chasm and the huge challenges that exist. But you are here now, so don't go away. Walk with us the rest of the way.
I wonder if Professor Gaurav has some comments on what he's heard in terms of how these innovations have been taking equity on board.
Absolutely. So thanks a lot, Professor Bloom. So it's very important for us as academics to also start questioning whether the development of the markets that we talk about is in the right direction or not, because there is some normative perspective that comes in. Indeed, the role of the state to help some of the innovators attain scale is very important. But from at times, if you put on that critical hat, you wonder, how do we go on to evaluate the effects or the impacts of these interventions and programs? And that's where it's very important for academics and researchers to start interacting with innovators and the government as well, in trying to understand the possibilities of identifying outcomes that are measurable and trying to understand what sort of durations are we talking about, what sort of effect sizes are we talking about, if there is an impact evaluation perspective. So I believe, since we've also been engaging with the tech side quite frequently, apart from just the social sciences or the economic evaluation perspectives, we also believe that everybody has to really start sharing their learnings, as you rightly asked in the beginning, because the pandemic was perhaps once in a lifetime opportunity for all of us to try to see what worked and what did not. But in the post-pandemic scenario, it's important for us to really leverage on those learnings and the platforms that both Shipra and Sanjeev have very nicely elaborated on, as Sujata ma'am was also nicely presented, that the state is playing a very important supportive role there. But we also need to start thinking on the questions of regulation, that at some point are going to be a cause of concern for several actors and stakeholders in this context. If there is any uncertainty or ambiguity about standards and the regulatory framework, what should we do as a larger collaborative framework to really address these concerns and make sure the initiatives go ahead unhindered? So that's pretty much my early impressions about these questions. Thanks.
I have one more question to kind of just tack on to what you've already said. And it's really about what are the responsibilities that researchers can really have to contribute to some of the debates that you've articulated. You talked about, for example, having a framework on inclusivity, for example. You also talked about the fact that there is the equity equality divide. It's a digital divide, and increasingly it's going to also impact the kind of people who use digital devices. The elderly, for example, who may not have or not know how to use a smartphone, peri-urban and rural communities that do not have the kind of digital infrastructure to be able to access a telemedicine platform, or for that matter, even a counseling session on the phone. So how can research really help work with, say, a state government partner or even the private sector partners or the non-state actors here to kind of build on that body of beginning to think inclusive design? So some comments on that.
That's indeed a very important question, because if we start asking ourselves as to do we know what we're trying to measure, pretty much what I mentioned earlier, then we realize that many times we do not have neat definitions of these constructs that we're going to capture. There could be issues about even operationalizing these constructs. There could be agreements and disagreements among the stakeholders as well. So I believe that if we have a framework in place that will give us some guidelines or directions as to what should we as a group who has a certain stake in this larger solution be aspiring to. So if you're aspiring for larger impacts on certain specific indicators that are definitely measured and you're able to construct those, then the academic evaluations are fairly straightforward. But I believe in much of the questions that you indicated, there's going to be a serious challenge of separating the importance of access and that of accessibility and the other aspects that come up in our understanding of this multidimensionality of equity. So one direction that one set of researchers in our core group have been started working on is the idea of multidimensional inclusivity. So we're trying to do that in the context of poverty. We fairly know that poverty is not just income poverty or consumption poverty. Similarly, inclusivity in a digital health context in particular cannot just be access, or inclusivity in terms of a certain age group being included and so on. There are a lot of complementarities and a lot of, I would say, differences that might arise in terms of our understanding of what works and what doesn't for a certain dimension also. And as academics, we would love to engage with all the stakeholders in refining some of these frameworks and constructs.
Great. Thanks, Sarthak. Jerry.
Well, I guess I would be, I think that those were sort of provocative statements. It would be good to hear the startups, how they think about working with researchers and enabling them to have a look at underneath the surface about what's happening and who's benefiting. Is this something that would be valued or something that would be difficult?
Very valuable, because as a startup, what you're trying to do is bring innovation that's helpful, that's going to do what it is set out to do, and one can only play their role to perfection and work with others who are more adept, who understand the framework of equity better, who understand the framework of evaluation better, and then help you chart your course so that your goals are met. I mean, at the end of the day, that's a relationship which is a win-win for all. I know that any stakeholder relationship has its own differences, and there will always be challenges or working together. But that's the only way you can sustain a solution. If the solution wants to work in isolation, then as soon as the pandemic goes, or even if it subsides, the solution also will go with it. I mean, for it to continue and for it to have a certain life of its own, it has to work with the stakeholders who can enable it to look at places where it needs improvement and work on dimensions where it's already working good, and facilitate that further. So I think the only way in which the mixed health systems can evolve and work is when the state actors and when the academia and the non-state actors can come together.
Well, and let's ask Sanjeev, who raised this question of sustainability.
Yeah, so I kind of echo what Shipra is saying. We are already starting to get involved with academia, and incidentally, it's academia that approached us saying, "Hey, we'd like to be able to understand what your impact is. We'd like to be able to research certain outcomes, and so on and so forth," which were things that were not on our mind at all because our focus was on delivery, our focus was on operations, right? So having academia in the mix, by means of which one can actually do a stringent monitoring and evaluation and look at very, very concrete outcomes, which will then continue to drive quality improvement over iterations, I think is something that is essential for any development in this field, as such. There was one professor who came and said that I believe that he formulated a hypothesis saying that, so many number of hospital beds were available as a result of your intervention, right? And when somebody else in academia came and he challenged him and said, "What's the premise behind your hypothesis?" We started to dig deep into it, and we said that although in theory that did in fact happen, it would be very difficult to be able to present any evidence to say that these are the number of beds that happen. So, and if you don't have that data, then how can you replicate that model? So academia becomes an important aspect of any healthcare delivery system, according to me.
But then I guess I would ask Madam Sonik, because you mentioned platforms that you were already developing before the pandemic and asking startups to be learning. Where do you see this model of a learning approach to startups in innovation and a learning approach to linking these online activities to on-the-ground activities, which I guess are largely government? How do you see this structured, this kind of learning?
I think each one of us have a very important role to play. For example, I would suggest that the startups should consider working along the sandboxes that the government has created. For example, if we have an Aadhaar KYC sort of an approach to providing services to our citizens, then the startup should probably also continue to use these systems rather than creating a parallel set of data. Then it will be very hard for us to read much out of it. For the academia, I feel that if they were to work along with us and looking beyond just numbers, if they could help us with trends and bring to our attention areas where they feel that not enough has been done, because we are discussing in this webinar the need to reach the unreached, which are those segments of society who have been disadvantaged due to the digital divide. Then how is it that government can reach out to them? It's interesting, I was reading somewhere that almost 97% of people in the world are very close to a mobile cellular sort of a network. But 50% of the people, despite owning phones, are actually offline. They are not able to access services. We also found that initially when we started doing our vaccination drives, for example, people were not comfortable to go online and register and find out the nearest center, which was part of the COVID system. And it took some time for us to then run an awareness campaign and bring people up to board, up to how do you access these services. And today the system has been working rather well. Initially, of course, the system crashed, but it has been working well. So I guess the biggest takeaway for us as a government, it is challenging for all of us. Not just for the policymaker, it is challenging for the tech startup, it is challenging for the people, it is challenging for the academia, for the industry, everyone. It has been indeed the most challenging time that we've ever seen. But then we have to learn from whatever we have so far experienced and build on that in order to be ready for the next, whatever is following, and that's the only thing which is going to work in the long run.
So I just wanted to kind of follow up on a phrase that you used. You said parallel sets of data. And right now, there are innumerable tech startups across the country, all gathering data one way or the other. So, uh, I have a question that I would actually like to pose to all the participants today. And that is essentially, one for you, starting from you, Sujata ji, are there conversations happening within the government, within the Ministry of Health, on how to kind of navigate these data challenges? So at the end of the day, when you're going to, talk about scale, there is going to be that fundamental question of who owns whose data. And that's going to be very crucial in questions around equity and equality, because usually the most vulnerable populations are those, where there are no questions about data, privacy or protection. So, could you maybe talk to this a little bit, and we could start with you and go around the table?
Yes, sure. I think that's a very interesting question. Most of these health devices that are coming in the market today, they are capturing one or the other form of data. And in the Maharashtra Innovation Society, whenever we are onboarding any such startup, one of the first things we talk to them about legal issues, about use of the data that they are capturing. Depending on the involvement of each of these startups, they are either very well informed or perhaps not so much informed on a scale of 1 to 10. So one of our responsibilities is also to bring them up to speed about what are the challenges that lie ahead in case they are capturing data. So whether it's about consent of the patient from whom they are gathering that data, what they are going to do with it. Some of them don't know what to do with it, so it's just lying there. And some of them don't understand why in the first place they are capturing that information. However, a lot of information is being gathered, so we keep advising them and suggesting to them that whatever you are doing, make sure that you first of all understand why you are doing it and what you're going to use it for. If it's going to help you in understanding your own client base better, then you need to bring in some experts who can work with you, on those data sets and give you information. And for that, we always suggest collaborations. As I mentioned earlier, we have signed a couple of MOUs in Maharashtra for data analysis, and IIT Mumbai is one of our partners. And we do work very closely with them. So there are these institutions already available who can help to make sense of the information that they are capturing. For example, one very interesting data analytics which is currently embedded in IIT Mumbai is Haystack Analytics. And they are a group of professionals who are mentored by IIT faculty. And right in the beginning, the initial phase of the pandemic, they were helping to put out models as to the level of infectious sort of spread that is likely to happen. And some of these models were shared also to the central government, including ICMR. So there is a lot of scope in using that data to drive further policy. But to come to that point, to be actually able to suggest, certain policy interventions, I think is a lot of hard work involved, and you need to bring in very credible reports. I don't see that level of maturity happening immediately, but I'm confident that over time we will be able to explore this more and more and build our capacity.
Thanks, Sujata ji. Very quickly, Shipra, what are your comments on this? Data sharing.
Correct.
Yeah.
Correct. In case if we need to use certain data points to make the services better, then they are disclosed to the patient where the data will be used, and they are always anonymized. There's data tagging and annotation that goes into the process. And yeah, I mean, we are fairly HIPAA compliant because also as a mental health startup, you have to comply. Data is a huge puzzle of how your services are shaped up, and confidentiality is the key piece when it comes to patients' health information dealing with mental health. So we already have compliances around that. Working with the government, of course, the stakeholdership was a little different because the patient or the client wasn't directly coming to us, but was coming through a certain network and challenge. So there were a few hiccups there initially. I mean, to give you an example, one of the donors, one of the funders who funded a certain helpline, and this was not directly through ACT or other places. So they wanted to know who are the beneficiaries of this and whether they could have access to their data. And that's where we completely put our foot down that fund or no fund, we are not going to fudge on our responsibility when it comes to a HIPAA compliant startup, and in divulging any form of personal information of any user, and giving away any information that can compromise someone else's discussions that they've had in the process of their journey of treatment for mental health with us. So while the systems are there in place, but it's a lot of work in progress, and I think this is shaping up globally as well.
Thanks. Sanjeev, very quickly, thoughts on data.
Yeah, so whenever we signed any contract with any government, there was a legal document that clearly spoke in terms of how we do the data management, and we complied to all of that, right? However, I don't think that that's enough, because at the end of the day, while we are fully compliant with whatever the government asks of us, we have to think about all the stakeholders, and in the healthcare ecosystem, really, which is, I think, one of the most complex ecosystems. If you look at all the multiple stakeholders and if you look at the complexity of the data set in the healthcare system, I think that there has to, over a period of time, has to be the emergence of a health information exchange standard, so to say. Now, mind you, in the West, HL7 is standardly used in terms of exchanging information between different applications of the standard language, right? But in terms of health information exchange is something I don't think, that those guidelines have clearly kind of emerged in India. And I think that's going to take a little bit of time for that to unfold, given the fact that telemedicine was pretty well illegal till March of 2020. So data was not at the forefront of healthcare service delivery, but that's all changed now. And in fact, I know that there are some groups working in Delhi that are working on defining what these standards are in terms of health information exchange. But for us, we're pretty clear about the fact that all information must be encrypted. All information is, whenever any information is analyzed and aggregated, it is always de-identified so that confidentiality is always maintained. And we always have a complete history in terms of what happens at a transactional level with every single record.
Okay, great. And Professor Sartap,
thoughts? So I agree with the thoughts of my colleagues, because one challenge that the startups as well as the government is going to face is an apparent tension between the definition or the lack thereof of what is called commercial purpose. So the specific law that was proposed, the Disha Act, or 2018. So that says that data collection, storage, transmission is not permitted for commercial purpose. While the general law, which is a bill that is in the state, this is the Personal Data Protection Bill, when the day it becomes the act, it is going to ban any kind of activities that is not so defined, but it would allow activities for commercial purpose. And then this would be challenged by the specific law, because in India, the specific law will override the general law. And that's going to create a lot of concerns for the stakeholders. And I believe pretty much in line with what Sanjeev has rightly mentioned, that we have a long way to go. And that's where, even if we're thinking about NEHA, which is the National Electronic Health Administration, and we're talking about the National Health Policy Portal in particular, trying to give out information and have a democratic and process wherein we get feedback from the public in terms of the bills being circulated. So the idea there is, once they become an act, there is scope for amendments that could very likely, if there are certain interest groups that believe it is thwarting their efforts to achieve certain impactful and other sort of commitments in the digital health space, I believe there will be potential amendments to laws as we go ahead, but that's something that could happen in the near future. So that's pretty much where I believe we have to start being more aware about the legal aspects of the business, as well as what entails and what doesn't entail so-called commercial purpose in the digital health space.
Thank you, Professor Sartap. We have only about 2 minutes left to wrap up. Jerry, any last minute parting thoughts? And I have one last question that I want to put to the tech entrepreneurs, because that's something that we really need to touch upon. But anything else that you'd like to cover that I may have missed out?
My only comment would be to come back to the language of audacious and the pointing out about the great importance of equity. And, I think the challenge is, can this audacity continue? Can the investment, which sounds enormous, not just for startups, but for startups working with government, working with researchers to generate learning about what works and how to improve things, it sounds to me like this is the beginning of a long journey. And thank you, everyone, really, for launching this discussion so well.
Yeah, thanks, Jerry. And I think in parting, we have just about a minute left. I'm going to quickly start from our techpreneurs. Going forward, what kinds of civil society groups and community groups do you want to build relationship with? Because that's what is needed to kind of bring these conversations forward. And it's very important to include them in digital design of the future. So 30 seconds, starting from Shipra. Go ahead.
Yeah, so that's a great question. I think anyone working in the community healthcare system, that's directly, the CHC and PHC level of work, they are the ones who own maximum amount of data and information around how do you bring in inclusivity in your design. It's okay to think as a startup about cool things that you can do, but when you actually go on the ground, you fail and you're surprised suddenly by knowing certain nuances that you were completely not aware of. So that's one partnership that needs to kick in. Another, really, for working with governments, I think our experience with MSINS in Maharashtra was really fruitful. So organizations from the government that support innovation and that become like a space where startups can explore and the government can meet, and one can have very niche goals. So like we are a mental health focused startup, we exactly know what we want to do. Those kind of arrangements really allow you to do the best without getting buried into too many processes and steps and not really getting your services out in the right manner. So I think, yeah, those two will be critical.
Thanks, Shipra. Sanjeev.
I will agree with Shipra, and I will say we would like to add employers to the entire mix, because employers have a vested interest in ensuring the well-being of their employees, and it becomes a very, very mutually symbiotic relationship. And I'm not talking of MNC employers. I'm talking of employers in rural areas, the factory workers, all of those kind of people where the healthcare is compromised. They are people who are left out, and everybody kind of wins as a result of that. So we're looking at that as a model already, even from an economic perspective.
Perfect. Thanks, Sanjeev. Madam Sonic, parting words.
I would say that, digital healthcare transformations are already here to stay, but we should be very watchful of not allowing certain sections of the community to remain out of that sphere of influence or benefit of these tech solutions. So I think both sides have to work towards making sure that the healthcare technologies that we are promoting or working on are equitable to all.
Great, thanks. And finally, Professor Sarkar.
Well, as an academic, there's so much which is work in progress. And I believe it's a great opportunity and also an invitation to all of you and the partners in the tech scale, also the healthcare space, to come and interact with us and see where all of us could collaborate and contribute to solving these wicked problems as we go ahead. Thank you.
Great. Thank you so much. This has been a fantastic discussion. And I think the future of digital health ecosystems in India and across the region will increasingly be about building these nuanced relationships with community groups and the civil society so that we can have a more sensitive and deeper understanding of the needs of vulnerable and marginalized populations who will need many of these complementary digital services the most. That is the future, and we are delighted that you are able to join us today for the session. And please look out for the next session where we will move the conversation to matters of accountability, the role of regulation and the law, what's an ideal framework for digital health ecosystems are going to look like, coming up in January with Ikigai Law. So thank you again. Thank you all so much for joining us, and we'll be in touch. Thank you.
Thank you.
Thank you
for the opportunity.
Good to meet everybody.
Good to see you.
Thank you.
Thanks.
Take care.